Hi everyone, and welcome to the new episode of CardioBuzz as we dive into an exciting and transformative topic that has the potential to change the landscape of cardiology forever. We still, despite all the advances in medications and interventions, we still have patients who exhaust all the available therapies, like advanced heart failure or resistant angina, where we use everything, all the medications, the procedures and the surgeries, and they still suffer. So could heart disease be treated at its root by regenerating the myocardium?
Welcome to CardioBuzz, your one-stop shop for all things cardiology. We bring you the latest updates on heart health, including the most recent guidelines. We interview the experts and try to answer the difficult clinical questions of everyday practice.
Stem cells are unique cells that have a remarkable ability to develop into different cell types in the body. They can become muscle cells, they can become brain cells. They serve as a repair system, and they hold an immense potential for regenerating damaged tissues and organs. This ability makes them a very powerful tool in medical research and therapy for cardiovascular diseases. Stem cells seem to be a revolutionary approach to healing the heart from within. And this cutting-edge field is not just a glimpse in the future, it's happening right now. However, it's important to note that there is some conflicting evidence and some skepticism within the medical community regarding the effectiveness of stem cell treatment. So we're thrilled to explore this fascinating and controversial topic with one of the world's leading experts, Dr. Yahya Kiwan. Dr. Kiwan is an eminent cardiologist with over 4 decades of experience. Dr. Kiwan is not only a senior interventional cardiologist, but he's also leading stem cell research and he's a stem cell advocate. Throughout his career, Dr. Kiwan has directed cath labs, managed cardiology departments across the globe. He holds an impressive array of qualifications, including memberships and fellowships from the Royal College of Physicians in London, Glasgow, the American College of Cardiology, and the American Board of Regenerative Medicine. Currently, he serves as the Program Director of the American Board of Regenerative Medicine Fellowship Program, and he's a member of the Working Group on Cardiovascular, Regenerative, and Reparative Medicine in the European Society of Cardiology. He has authored several publications and book chapters on the role of stem cells in cardiology and continues to be a passionate educator and a mentor in the field. Welcome, Dr. Yahya.
Thank you, Dr. Hussain, for giving me this opportunity related to stem cell therapy. This is my new baby. This is my new subspecialty, and I'm leading the cardiology community for awareness of this very promising field, especially in post-myocardial infarction and in resistant chronic heart failure. As you mentioned, there is really, we have like a polypharmacy for heart failure. We have many devices, but we did not really significantly decrease the mortality. We did not really decrease the significant rehospitalization and so on. There are more than 11,000 research and clinical research done exploring the abilities of stem cell therapy to treat disease in all medical and surgical subspecialties like plastic surgery, orthopedic, skin, respiratory, cardiology, neurology, you name it. In cardiology, we have more than 1,138 registered phase 1, phase 2, and phase 3 trial in the NIH, more than 1,000. And more than 800 already published. Now, the summary of this 800 trial that almost all have shown the safety profile of stem cell, which is the most important part. Everybody asks, are they safe? So safety, there is no doubt about it. On the top of that, it shows efficacy in treating many conditions, mainly those on post-myocardial infarction in the first week after primary PCI and in chronic resistant heart failure.
That's great. So where do we bring the stem cells from? From the umbilical cord, from the placenta, from the bone marrow? Where do we harvest these magic cells?
There are many sources. First started with embryonic stem cell, where at that time the little embryo was taken out and the stem cell taken from it and then used in a clinical trial. And then the ethical issue came, so embryonic stem cell has been totally replaced with adult stem cell. Adult stem cell can be obtained from umbilical cord blood, umbilical cord wart and jelly, from the placenta and amniotic fluid. This is one source. We have a source of bone marrow aspiration, which is full of stem cell. There are 2 types of stem cell. The hematopoietic stem cell was used by hematologists since 60 years for bone marrow transplantation in chronic hematological malignancies. Actually, when we talk about stem cell, we don't talk about the hematopoietic stem cell of malignancy. That's already well documented. There are other type of stem cell in the bone marrow called mesenchymal stem cell, which is our point of interest nowadays. The third source is adipose-derived stem cells. We have a lot of stem cells dormant in the fat. We can take them, isolate them, expand them, culture them, and re-inject them into the same person or other people. And by the way, each tissue in the body, the heart, have a dormant stem cell. The brain has a neural stem cell in the liver, in the intestine, everywhere. But the commonly used sources, the three which I already mentioned.
That's great. So once we harvest and have these cells, then we have them in the lab and then we inject them into the human body, right?
Yep. So we take them because the amount of cells, as you know, we need a big dose. The amount we get them from the fat, from the bone marrow, and from umbilical cord is not enough. So we have to take them, feed them, expand them, culture expand, and keep them stored in a bank and can be used at any time in any dose. The usual dose is minimum we need 100 million per injection, intravenous or intrathecal or local injection. So that's what we do, store them in a bank.
So everyone has his own stem cell. We cannot use from one person to the other, right?
We can. Thank you for bringing these really very critical questions. Now, the earliest treatment was they used autologous cell. Autologous means, for example, bone marrow transplantation. The first initial trial, they used bone marrow autologous cell where your own bone marrow aspirated, separating the mesenchymal stem cell, either direct injection if you don't need large amount or culture them. So that's called autologous. The same thing, fat. You take your own fat, aspirate, separate the fat, remove them, get the stem cell, culture them, expand them, store them, and re-inject them. That's autologous. However, you cannot have umbilical cord autologous cell because that should be coming from a newborn baby. So that's called allogeneic. Now, there was an initial big issue of like reaction or allergic reaction or do they need a cross-matching or not. After the research and all the trials, the conclusion is very simple. Allogenic umbilical cord or bone marrow cell or fat cell from other people does not cause rejection or reaction because they don't have the HLA antigen on their surface. So there is no risk of getting allogenic cell from other sources and inject them to any person.
That's very good to know. So now these stem cells, we have them in the lab, we populated them, we culture them. How do we inject them so that they reach the heart? Should we inject them through a surgery, through a catheterization, or intravenous? How do they reach the heart?
This we call it the root of stem cell implantation in cardiology. The first trial started like 2 decades ago by direct open heart surgery, where the stem cell taken from the lab and injected over the scar area, hoping that it will regenerate. That's lasted for like a couple of years. And then the technique came of subendocardial injection by a needle catheter, injected direct to left ventricle under fluoroscopy and scintigraphy, where we know where to go, what is the scar area, and then injected through a catheter. So that's called subendocardial needle injection. And after that, because it is a complicated, people moved into direct intracoronary. So currently, the most acceptable technique is intracoronary infusion of stem cell therapy. However, there are people believe there is no need to go direct to the coronary because the cells nowadays function through a paracrine effect. Paracrine means if you inject the cell, they can sit anywhere in the body and they can secrete secretome, exosome, vesicles, and growth factor. These secretion from the cell are attracted by factors secreted from the damaged tissue. So it sends a signal to the stem cell where it is sitting anywhere in the body. And after that signal, the stem cell looks for so-called homing. Means they look for a home to go and circulate and go to the damaged part of the body. So people now shifting from the intracoronary infusion to a very simple intravenous infusion of stem cell, hoping they can reach anywhere in the body, including the brain.
That's great. Then that makes life easier, and they seem to have the potential to heal more than one organ at the same time if we inject them intravenous. That's interesting. So, what are the current applications in coronary disease and in heart failure? Who should get stem cells?
Okay, I think there are 6 or 7 indications in cardiology. There is a clear evidence in post-myocardial infarction first week intracoronary injection. It decreases the incidence of reinfarction, improve ejection fraction, and it prevent the future development of heart failure. Number 2, chronic resistant intractable angina. Very strong evidence in the literature that people with intractable angina on polypharmacy who are still resistant to medication. Resistant means intractable, and there is nothing to do, like you have done multiple stenting, you have done bypass surgery, and there are more than 8 medications. Adding stem cell therapy on the top of their medication significantly improve. Remember, Dr. Hussain, improve the anginal episode, decrease the anti-anginal medication, decrease the angina severity, increase exercise tolerance, increase ejection fraction, and on the top of that, increase survival. People on stem cell live longer compared to patients without stem cell therapy. So that's in intractable angina. We have very strong evidence in heart failure, the 2 types of heart failure, ischemic cardiomyopathy and dilated cardiomyopathy. I'm just mentioning example because there are hundreds of trials. Example, MSCHF, IX cell DCM, Regenerative DCM, Concert heart failure, Dream heart failure, Booster TAHA 7, and Prevent TAHA 8 trial, in addition to many well-designed meta-analysis of randomized controlled study demonstrated efficacy signals in post-MI and in heart failure. There are good evidence also in microvascular coronary artery disease. There are 2 good trials showing that the patient symptom has significantly improved and the myocardial resistance has significantly decreased after the injection of stem cell therapy intracoronary. There are other applications, of course, and we have limited time, congenital heart disease, and also in cardiac surgery where people nowadays trying to, the xenograft, fill it with millions of stem cells on the top of xenograft and implant it to prevent fibrosis, calcification, and increase the lifespan of tissue banks. So this is summary of application. I mean, I can't keep on and on, but I believe we do have very strong evidence.
Do we have any success stories or case studies where stem cell therapy has significantly improved the patient's outcomes?
Yes, definitely. We have many successful stories. There was a book published in America, published by patients actually. And many of these patients, when they started, they have significant symptoms of heart failure. Their ejection fraction was really low, and they were put on the waiting list of heart transplantation. While they were waiting for cardiac transplantation, they received intravenous infusion of stem cell. Many of these people, their symptoms improved, their ejection fraction went up, and on top of that, they were removed from the waiting list for cardiac transplantation.
That's impressive. But why don't we see stem cells in the guidelines? In the heart failure guidelines, in the American College of Cardiology guidelines?
Hussain, believe me, I have attended many of the lecture arranged by Cardiac Society. 3 of the conference I attended, I was like a very, an unusual stranger when I gave my presentation. I could see everybody what Yahya is talking about. And at the end, they asked me a question, and my question to them, to the bosses or to the chairman or to those people who are in charge of conference, I say, please, why don't you consider it in the guidelines? And I know the answer, because we have issues with what type of cells to give, what is the route of the injections, and what are the ideal dose given to the patients, and so on. This is a concern and question asked, but it should not stop us from putting the stem cell therapy at least in the guidelines. But you are asking me, I have no answer. I am a bit frustrated, but look, we will never stop. We will keep lecturing, education, certification, awareness. But believe me, Dr. Hussain, one day, all of us, we will prescribe stem cell therapy. I don't want to say over the counter, but at least it will be regulated. Just to mention that the DHA in Dubai has very clearly regulated stem cell therapy, especially in the subspecialty of neurology and heart failure. And they clearly mentioned if you want to give stem cell therapy, you have to go through ethic and research committee of the DHA, submit your protocol of research, and if that protocol accepted, then they are more than happy to give you the approval to start your clinical trial. But as you know, preparing for that is not easy, but this is a very positive step forward that we are slowly and gradually believing that there is, in the sense that stem cell therapy is going to be the future of cardiology.
Maybe what we are lacking is some industrial support. So now, as we were discussing, if one human can donate stem cells to another human, what are the ethical considerations for the stem cell research?
Okay. Of course, the best cell in the planet is embryonic stem cell. But because of ethical consideration, because it involves sacrificing the embryo, nobody is using it. We don't need them. We have many sources of stem cell. I need to mention something or one cell called, remember this terminology, Dr. Hussain, induced pluripotent stem cell. Induced pluripotent means this is equivalent to embryonic stem cell. It can create any type of cell like any embryonic stem cell. However, it's very easy to produce. It is produced from somatic cells. There is a scientist Japanese called Yamanaka. What he did, he took a skin fibroblast, which is somatic cell, and he gave it some transcription factors, and he changed them into an embryonic-like stem cell. That's why called induced. And it is pluripotent, means this cell can become any type of cell. So basically, we have embryonic stem cell created from your somatic cell. And this is going to replace all type of stem cell. Actually, it has been transferred into cardiomyocyte, has been transferred into retinal cells, has been transferred into pancreatic islet cell to treat type 1 diabetes and so on. So the future of regenerative medicine is induced pluripotent stem cells. So talking about ethics, there is no, please, that I want the audience to understand, there is no ethical issue because we are not using any more embryonic stem cells.
That's great. And so you already mentioned the future perspectives. So we expect mesenchymal cells from our body to be pluripotent cells that can be used anywhere, right?
Yes, somatic cell.
Before we conclude, Dr. Yahya, where can doctors learn more about, where can cardiologists learn more about stem cells? Is there a special fellowship or course for that?
In fact, I am a diplomat of American Board of Regenerative Medicine. I am a fellow of ABRM and recently elected as International American Board Regenerative Medicine Ambassador. And on top of that, I have asked the boards of directors to create a fellowship program. So I am now the program director of the American Board of Regenerative Medicine Fellowship. It's not only by name. I am working on a fellowship program, which we have the outline for that. Basically, it involves like a 2 weeks didactic lectures and practical applications and videos about regenerative cardiology, starting from physiology, pathophysiology, clinical applications, and the future of cardiac regenerative medicine. So I would expect after 3 months, the whole curriculum, which is huge, will be available. After the curriculum of the fellowship be available, I will formulate and create my team. And the team will be, I'm sure, consist of scientists, because I tell you, we are MDs, doctor. We 100% depend on our scientists, because they are the ones who are teaching us what to do and what type of cell and the dose and so on.
So it was a pleasure having you, Dr. Yahya, in this episode. I hope that the audience got just a glimpse of the future of stem cells, of regenerative cardiology. I will put some links to the American Board of Regenerative Medicine. And for those who are interested, they can follow that link and get more info about regenerative medicine, especially in cardiology.
Thank you very much, Dr. Hussain. And I hope my colleagues, cardiologists, spend some time and listen to the regenerative medicine in general and regenerative cardiology and especially. Thank you so much.
Thank you so much, and see you in the coming episode.
If you enjoyed this video, don't forget to hit the like button, share, and leave a comment. Make sure to subscribe to the channel and hit the notification bell so you never miss an update. Thanks for your support. See you all soon.